So continue about auscultation of the lungs. What it is in auscultation, in fact, and from Latin language, it's auscultatio, ausculto, like a listening. And auscultation is a study of a sound phenomena that independently arise in the body, and it is carried out by applying an ear, exactly by the ear, or an instrument for listening to the surface of a person's body, to the human's body. And in this regard, we can separately two types of auscultation, direct and indirect. Surely, more important for us, it's indirect type of auscultation using special devices for auscultation, your own devices like a stethoscope or phanendoscope. So, all during this lecture, we will discuss an indirect type of auscultation. Surely there are some rules of auscultation of the lungs. The room in which auscultation is performed should be warm and quiet. The room should be absolutely quiet because from this condition depends the level of the hardness of this oscillation. Doctor hands should be treated with liquid soap and antiseptic after and before each patient. The naked body should be listened to with a warm stethoscope. The head of stethoscope should be warm for more comfortable for your patient. And the phanendoscope should be pressed tightly against the surface being listened to, but without any pressure on the surface on the chest, as this can reduce the sonority of the head noises. So the putting of the head of stethoscope or phanendoscope should be tightly in any point of auscultation. The patient breathing should be even and calm, although if necessary. We can ask a patient to make a deep inspiration or a deep expiration to check some difference in the maximum inspire and the maximum exhale, to check and to analyze secondary respiratory sounds. Also, we can ask a patient to take a breath with the open mouth, yes, because some another condition to check during calm breathing, but with the opening mouth. But pay attention that the deep breathing with the opening mouth can lead to hyperventilation of the lungs and can be cause of the dizziness and till the fainting. So you ask a patient during such type of auscultation about condition of the patient, and maybe try to support the patient by the back for not fainting. Also, you need to hold the phanendoscope with 2 fingers, the head of the phanendoscope, and the doctor's fingers should be motional, tightly pressed to the phanendoscope. It's the main basic rules of auscultation of the lungs. So, about the place and the points of auscultation of the lungs. In fact, we cannot discuss that it's comparing auscultation, but on the base, it's really comparing from the right and left heart of oscillation during auscultation technique. So about points for auscultation, it will be similar points, 4 points for comparing percussion of the lungs. So you'll start from the right region in the apex, in the apex of the lungs from the right side, next left. The same, you have to comparing the similar oscillation from the both sides, right, left, next, 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 next. Look, from the left side, you can miss like 2 last intercostal spaces, because there will be place, but you can some move the state of phanendoscope. I can continue making auscultation by the mid-clavicular line from the left side, and by the right side you can continue to the level of the 6 intercostal spaces. It's points for auscultation technique on the anterior part of the chest. After that, you ask a patient to turn his arm up, yes, and continue and continue your auscultation methodic in the lateral part of the chest. Look, there is no special anatomical features, no anatomical orientar for making auscultation on the lateral parts. But you need to know that there is some difference in the structure of the right and left lung. So on the right lung, we differentiated 3 zones, upper, lower, and middle. And on the left lung, we differentiated only 2 lobes. Yes, it depends from the structure of the pulmonary tract. And so you need to put stethoscope in such additional area from the right side to make an auscultation of the middle lobe of the right lung. But in fact, you can put the head of stethoscope in all faces of the lungs. Yes, it does not matter really methodic and scheme of auscultation, because you can make an auscultation all faces of the lungs. Look, lateral part, anterior part, lateral part. After that, you ask a patient to put his continue auscultation on the here and from the group number 4. Please switch off your microphone. Thank you. So then you continue auscultation on the back side. Surely you start from the suprascapulous regions, then interscapulous regions, maybe 2, maybe 3 points from the both sides, but the main, pay your attention that right, left, right, left, right, left to compare this oscillation. And then under scapulous regions. So it's all faces of the lungs, anterior, lateral part, back part. So during your examination, you need to have in your mind projection of the healthy lungs on the anterior and posterior part of the chest. So it's all about technique of the auscultation of the lungs. But the most important in auscultation of the lung, it's not about technique, it's about interpretation and determination, the type of respiratory sounds, and try to understand in which difference you'll find right now. So all sounds which are heard other than lungs, we can differentiate it by 2 big groups. And first of all, it's main respiratory sounds, and another one, it's secondary respiratory sounds, or sometimes additional respiratory sounds. It's the same, secondary and additional respiratory sounds. About the main respiratory sounds include various types of breathing, some of which are heard other than normal lungs, and other in the presence of pathological changes in them. So normally in healthy lungs, we can differentiate it one type of breathing, in pathological condition, another type of breathing, yes? But it's the main respiratory sounds like a background, like a phone for additional. Secondary respiratory sounds include sounds that are formed in the lungs in excess of the respiration, normal or pathological, and are heard simultaneously with it, the main respiratory noise or type of breathing of the main respiratory sound, and secondary respiratory noise, such as wheezing, pleural friction noise, crepitation, and pleural pericardial noise. It's the main type of additional sounds. So, by classification, all respiratory sounds differentiated into 2 big groups, the main and background like a phone, and the secondary or additional respiratory sounds, which formed only in pathological condition and can be heard simultaneously with tertiary or primary respiratory sounds. About the types of breathing of the main respiratory sounds. So the main respiratory sound above the all faces of the healthy lungs, it will be the vesicular breathing. What it is, the vesicular breathing? The vesicular breathing is heard on the large surface of the lung tissue. This is a gentle breathing noise, reminiscent of the like a sound letter F, like a if you try to pronounce it, you have to try to pronounce it, slightly drawing in the air. And vesicular breathing is formed when the alveoli expanded, the air enters the respiratory teeth and is associated with the tension of the elastic elements of the alveoli. So the main mechanism and the main point of formation of vesicular breathing, it's exactly the cavity of alveoli and expanding the wall from each other, expanding the walls of the alveoli from each other in the phase of inspiration. And one of the varieties of the vesicular breathing is a pleural breathing. Absolutely the same mechanism of formation as pleural breathing, but had in the children and adolescents due to age-related anatomical features of the structure of the lung tissue and with a thin chest wall. This breath is sharp and louder than the breath of adults. So the same mechanism, but more sharper and louder than the breath of adults, cause the structure of the chest wall will be more thin and more better audible, such type of breathing like pleural. Look to this picture. It's a slide about formation of vesicular breathing and mechanism of formation of vesicular breathing and such special characteristic of this type of breathing. Look, we discussed with you that the main mechanism is expanding the wall of alveolus in the phase of inspiration. And look, it's direct of the air. Air enters in the bronchus, then in the distal part, in the distal types of bronchus, enter to the alveolus. Yes, and this volume of the air expanded the walls of the alveolus from each other, and in fact, the formation of vesicular breathing, it's movements of the elastic wall of the alveolus due to phase of inspiration. That's why we can take information about more detectable and more in which phase of the respiratory cycle vesicular breathing will be more detectable. And look to these points. Yes, it's graphic of the respiratory cycle. Look, its angle, it will be a border between the phase of inspiration and expiration. So before this point, it's phase of inspiration. After, in phase of expiration. And look, more detectable the vesicular type of breathing on the phase of inspiration, and only first, third part or short type of expiration. Why? Because expanding of the wall of the alveolus is present on the phase of inspiration, because on the phase of expiration it will be passive re-expanding movements of the wall of the alveolus. So that's why we will determine vesicular breathing on the phase of inspiration and some short part on the phase of expiration. So, and it will be sounded like a so more longer phase of inspiration, the higher vesicular breathing, and then only short time of phase of expiration. So like sound, cause mechanism formation, it's a summary from the expanding walls of the alveolus, head on the phase of inspiration, and only short, only 1/3 of the expiration phase, we can detect the vesicular breathing. It's about vesicular breathing. And look, in healthy person, about all phases of the lungs, excluded 2 zones, we have to determine vesicular type of breathing. Normally, let's returning to the slide some after discussing laryngotracheal breathing for better understanding what I want to explain to you. Look, next type of breathing, it's laryngotracheal breathing. It's also a type of normal breathing, and we can determine it in healthy person. But this breathing such difference from the vesicular breathing, because the curves and loud of breathing, laryngotracheal breathing, similar to the letter and sound, more heavy, like a sound after letter H, yes, more heavy, more loudy, more stretch of breathing is due to the turbulent airflow and associated with the vibration of the adjacent dense tissue in the larynx and in the upper part of the trachea. Turbulent airflow is formed in the larynx and upper part of the trachea in normal both during the phase of inspiration and throughout the phase of exhalation. But moreover, the duration of nose on the exhale is somewhat longer than on inspiration. This is primarily due to the fact that during exhalation, the glottis is narrower than during inhalation. And it's physiological process cause this narrowing it's not exactly spasm, but it's narrowing of the glottis and trachea help to putting out and to putting outside this volume of the blood, this volume of the air after oxygenation on the lungs. So we need to more stretch and this narrowing more significant on the phase of expiration. Surely, yes, narrowing significant for turbulent airflow on the phase of exhale. That's why this type of breathing, like laryngotracheal breathing, more detectable on the phase of expiration than on the phase of inspiration, causes turbulent airflow, and we try to put out this volume of the air. And look at this picture about mechanism of formation laryngotracheal breathing. So it's larynx, yes, and it's upper part of trachea. It's place for formation of the laryngotracheal breathing. And look to the graphic of the breathing. It's phase of inspiration. After this point, phase of expiration. So we can determine this type of breathing on the phase of inspiration, but more longer and more determining it's on the phase of expiration. Look, cause narrowing of the glottis, narrowing of the larynx and trachea proceed exactly on the phase of exhalation. So that's why more detectable laryngotracheal breathing on the phase of exhalation. Pay attention, laryngotracheal breathing, it's a normal type of breathing. Right now, let's return to slate about vesicular breathing. We discussed right now that there is place for formation laryngotracheal breathing, yes, in normal laryngotracheal. Normally, through the trachea, then by the main bronchus, by the main different calibers bronchus, yes, and it's a way of providing this laryngotracheal breathing. But in healthy person, in case of healthy lungs tissue, the respiratory and vesicular breathing closing up this providing of the laryngotracheal breathing, and in healthy person, above the all faces of the lungs, on the anterior, lateral, and posterior part, we have to determine the vesicular breathing, because lung tissue normally summary from all alveolus and formation vesicular breathing, blocking and closing the providing laryngotracheal breathing to the lung tissue. But in this way, also, we can determine laryngotracheal breathing in healthy person in two zones. In above the all faces of the lungs, we have to determine vesicular breathing, but on the zones of the projection of the larynx and trachea on the neck part till the jugular notch, in healthy person we can determine laryngotracheal breathing. And look, the zone of projection trachea from the posterior part in the from the C7 till the thoracic vertebra 3 and 4. Yes, in healthy person, you can determine laryngotracheal breathing. It's zones for better providing, because it's zones of projection of the larynx and upper part of trachea. It's a and please not forget this picture. It's projection, blue color. It's projection of the vesicular breathing on the anterior part, yes, and look, excluded zone of the heart there. It's projection of vesicular breathing on the posterior part, and the red color, it's projection of the laryngotracheal breathing on the anterior and posterior part of the chest. So returning to the graphic image of the breath or graphic of the breathing. Look, first, it's a graphic of vesicular breathing. Vesicular breathing, more significant on the phase of inspiration, like a second one, it's a picture of the heart breathing. Heart breathing, it's also a type of vesicular breathing like a pleural breathing, but which difference? Heart breathing we can explain by a little bit bronchospasm, little bit presence the mucous exudate and swelling mucous substance inside the bronchus. So some swelling, presence a little bit exudate, presence a little bit bronchospasm can lead to increasing duration on the phase of expiration. So difference between vesicular breathing and heart breathing, it's duration, phase of inspiration and expiration. And in the case of heart breathing, yes, it will be the similar duration, both phases. So, and look to the last one graphic. It's a graphic of laryngotracheal breathing formation. Short phase of inspiration and more longer duration phase of expiration, which contact with the nerve of the glottis on the phase of expiration to putting out the volume of the air. So, laryngotracheal. So surely there are some variants of change in vesicular breathing like a main respiratory sounds. First group, it's quantitative changing like amplification and attenuation, and next one, it's quality like a heart breathing, like a pleural breathing, which we discussed already, and secondized breathing or intermittent breathing. So vesicular breathing differentiated and changes of vesicular breathing differentiated by two groups. Amplification, attenuation, important, and some difference, heart breathing, pleural breathing, and secondized or intermittent breathing. About attenuation or quantity of the vesicular breathing. Physiological attenuation or decrease in the loudness of the breathing is observed in healthy people at rest, during our sleep, in other people more than 80 years, in overweight people, and we discussed with you that overweight can be a reason of decreasing and attenuation of the voice trembling. So the same overweight can be a reason of attenuation of the vesicular breathing. In athletes and sportsmen, for example, with excessively developing chest muscles, cause additional lower of the muscles and increase in mass of the muscles can be a cause of attenuation, like a walking, like an additional lower, yes, like a stankel. Physiological amplification of vesicular breathing is detected also in healthy people during physical activity, during running, during exercising, with psycho-emotional stress in case of hyperventilation, in people with asthenic constitution, and with a thin and elastic chest and reduced body weight in children and adolescents. Physiological amplification. It means that more louder vesicular breathing. So physiological attenuation and physiological amplification. About the variety of vesicular breathing is a pleural breathing had in children and adolescents due to age-related anatomical features of the structure of the lung tissue and thin chest wall. This breath more sharp and louder than the breath of adults. So first variety of vesicular breathing by quality. Mechanism of formation of heart breathing. Yes, and remind about graphic of the heart breathing. Where is graphic? Where is graphic? Look, graphic of the heart breathing. The same duration, phase of inspiration and phase of expiration. So returning mechanism of formation, heart breathing. Heart breathing is a type of physical breathing as a result of narrowing of the bronchi, swelling of the mucous membrane, maybe presents a little bit viscous exudate in the lumen of the bronchi, a little bit bronchospasm. This free reason of development of the heart breathing. All these reasons can unite in one moment and can be separated. So the respiratory noise becomes more severe. It's not like a sound heavy, but more severe than a sound the normal vesicular breathing, and is heard throughout the inhalation and exhalation. Yes, and the main difference is the similar duration in phase of inspiration and expiration. And look, it's a picture with the mechanism of formation, heart breathing. If you try to assess the condition of the wall of the bronchi, look, presents some mucus, presents some swelling of the mucous membrane inside the lumen of the bronchi, presents a little bit exudate, and can be present some spasm, but no spasm in that picture. And look, air enter to the bronchus, the same mechanism, yes, but due to all bronchus, due to this way, it can be a reason of increasing duration of such sounds in the phase of exhalation. And look to graphic, the same duration, but heart breathing, it's a variety of vesicular breathing. Variety of vesicular breathing. It's not a separately type of breathing, it's a variety of vesicular breathing. So continue. Last type of vesicular breathing, it's a saccade or intermittent breathing. So the reason for saccade or intermittent breathing is the uninorming of the bronchioles in different parts, as a result of which the airflow meeting an obstacle, this neuron working like obstacle, in the way of the air and in the form of an unequal neuron of the various bronchi, and first penetrates into one part of the lungs, then into another part of the lungs. In this case, the breath is carried out intermittently and usually in 2 or 3 stages. Physiological saccade or intermittent breathing is detected in healthy people during psycho-emotional stress, during psycho-emotional arousal, and during muscle tremor. It's possible because during muscle tremor can be a reason of some blocking, some spasm of the bronchus, and so working like obstacle. And in children during a quick conversation or during crying, yes, and remind me, be crying, children, this type of breathing due to cry of small patient, will be working like a saccade breathing, because spasm, one putting of the airs, then another putting to another region, another putting, with working like a small pause between pushing of the airs into the legs. So saccade or intermittent breathing. And look to this picture. Look, airs enter in the bronchioles, so closing, but can go there. Yes, so first step, first push of the air, then by different reason relaxed and come in more deeper. Second point, just a minute. Second pushing on the phase of inspiration, yes, then opening in other more distal parts, So third point of pushing of the airs. So with small pause between pushing of the airs, like so pushing the portion of the air in the different parts of the lungs. Intermittent or succinate breathing. So all these types, yes, let's returning quantitative breathing, amplification and attenuation, and we discussed with you the physiological reason of the amplification and attenuation, and quality difference of the vesicular breathing, like a hard breathing, like a purer breathing, and like intermittent or saccadized breathing. Look, physiological saccadate, yes, during crying or during psycho-emotional stress and healthy people. About pathological attenuation of vesicular breathing. First of all, reason of pathological attenuation is emphysema due to a decrease in the total number of the alveoli as a result of the destruction of the interalveolar septa, and in the first stage, it's increasing in the volume of the alveoli. And second, reason with swelling of the alveolar walls of the lungs part, a decrease in the amplitude of their oscillation during the inspiration phase. And look to this picture. It's normally graphic vesicular breathing. Normally structure, air enters to the alveolus, expanded. The better example for understanding vesicular mechanism formation, vesicular breathing, it's imagine that these papers, this list of papers, it's a wall of alveolus. Yes, you put it together and try to enter air between these papers. So the sound from this expanding, it will be mechanism of formation vesicular breathing. Normally, elasticity wall of alveoli, it's the main point in formation healthy vesicular breathing. Look to picture B. Some shorter, some attenuation, shorter inspiration, small on the phase of expiration duration, while it's emphysematosis types of alveolus. What does it mean? Emphysematosis, that's airless of the cavities of alveolus in the first stage, and in the last stage, it's destruction, destroy all alveolus, destruction between alveolus walls, yes, and combining 2 or 3 alveolus in the one cavity. Imagine that before the phase of inspiration, before the phase of, look, it's normally, yes, before the phase of inspiration, the position of the wall of the alveolus will be re-expanded, yeah, will be together. So then air enters, this wall expanded, and these movements give us normal vesicular breathing. In case of emphysema, position of the walls of the alveolus before the enter of the air will be more separately. Exactly, air will be in the cavity of alveolus. So when air come in the cavity, yes, the movements of the wall of the alveolus will be not so high. So it will be a reason of attenuation of vesicular breathing. And the next situation, the same graphic, small phase of inspiration, too short phase of expiration. It's about swelling by the many reasons, but the main reason is swelling by inflammation of the alveolar wall. Swelling of the alveolar wall give such features to alveolar thicker of the wall. So more thicker wall leads to decreasing the mobility of the elastic wall of the alveolar. So air enters to the cavity, but no such elasticity, no the normal level of mobility of the wall of alveolus, less volume of the movements, less vesicular breathing. Next reason. So, emphysema, first reason, swelling of the alveolar walls. Next reason of the pathological attenuation of vesicular breathing. When a mechanical obstruction forms in the airways, for example, with a tumor, a foreign body enters, vesicular respiration is also weakened. Because the speed of the volume, speed of the air, speed of the enters of the air will be less. It's a reason of less volume of the airs coming in the cavity of alveolar, less movements, less vesicular breathing. In case of myositis or inflammation, respiratory muscles, inflammation in the intercostal nerves, bruises and fractures of the ribs, sharp weakness and adenoma of the patient. By the same reasons, it can lead to attenuation of vesicular breathing. In case of with the thickening of the pleural sheaths, accumulation of fluid or air in the pleural cavity, vesicular breathing sharply weakens or disappears altogether. It can present at all vesicular breathing above the region of ovation, or it can be a reason of pathological attenuation of vesicular breathing. And in case of thickening of the pleural sheaths, what's process of the thickening of the pleural sheaths? It's pleurisy, yes, thickening due to inflammation, different type of inflammation, but it will be pleurisy. It can lead to attenuation of vesicular breathing. Surely, accumulation and presence of the fluid and air inside the chest can be a reason and can lead to attenuation of vesicular breathing. During thickenings of the alveoli with inflammatory exudate with Crepitation pneumonia, during thickenings in the alveoli with inflammatory exudate, vesicular breathing may not be heard at all. So, like inflammation and presence inflamed exudate inside the alveolar cavity can be a reason like attenuation and can be a reason present not present at all vesicular breathing above the lesion. And look at this picture. So presence the fluid, hydrothorax, yes, fluid. Above the healthy lung tissue, you will determine vesicular type of breathing, but above the fluid and above the shear size, shear region, you will determine or attenuation vesicular breathing, cause liquid cannot provide in a good way with expanding sounds from the alveolus, and you will have attenuation of vesicular breathing or absence of any type of breathing on this area. Next, pneumothorax, pleural cavity, air. Yes, look, additional lower, not forget. Pneuma, it's additional lower. Yes, small area of the healthy lung tissue, small part. So there you can detect maybe in a little bit of the vesicular breathing, but about providing this type of breathing on the faces of the lungs, we cannot speak at this time, so we will determine or absence of vesicular breathing or attenuation of vesicular breathing. Next cause of attenuation of vesicular breathing is fibrosis or fibrothorax. Yes, some connective tissue after inflammation, after pneumonia, for example, fibrosis. And look, above this unchangeable lung tissue, you will determine vesicular breathing surely, but above the isolation areas or absence or attenuation of vesicular breathing. Next picture is obstructive atelectasis, and look to this triangle. It's pathological triangle of hyperventilation. In fact, no ventilation, no movements of the alveolus walls, no vesicular breathing. Sometimes vesicular breathing can be provided by these cavities, but sometimes not. So it's also a reason of attenuation of vesicular breathing. So emphysema of the lungs, yes, swelling of the alveolar walls due to inflammation, hydrothorax, pneumothorax, fibrothorax, and obstructive atelectasis. It's the main reasons of pathological attenuation of vesicular breathing. Also due to thickening of the pleural sheaths, yes, also presence of the inflammatory exudate, and also in case of myositis or inflammation of respiratory muscles, inflammation of the intercostal knees, and reducing the level of the inspiration and expiration. So, mechanism of formation and the main cause of attenuation, vesicular breathing. About pathological breathing noise and additional breathing noise. Look, what I want to say you also, that we discussed with you such type of breathing like laryngotracheal breathing, yes, and look, normally we will determine this type of breathing in these zones above the trachea, projection of the trachea, larynx, and above the projection of the trachea from the posterior part on the back of the patient. But look, it's normally placed for localization, laryngotracheal breathing. But in such condition, you will determine, for example, such type of laryngotracheal breathing on the zones when in normal you have to determine the vesicular breathing. And in these cases, it will be bronchial breathing, pathological bronchial breathing, yes? By the features, it will be the same features with the laryngotracheal breathing, and mechanism it will be the same, but it means that in this way, in this zone of the lung tissue presence, and it's a condition which can lead and which provoke providing laryngotracheal breathing through the lung tissue to the zones with normally vesicular breathing. So laryngotracheal breathing, it's normally breathing, but bronchial breathing, it's pathological bronchial breathing, but with the same mechanism of formation and the same features. But you will determine this type of breathing on the zones where in normal you have to determine vesicular breathing. Tell me clear this difference in laryngotracheal and bronchial breathing.
Yes, ma'am.
Yes,
Okay, Rutvi. Thank you.
Yes,
so, continue. So, additional or secondary breathing sounds or noises. And first one, it's wheezing with different quality, dry wheezing and wet wheezing. Look, I'll give you this classification like a dry wheezing, bass and treble, and wet wheezing, small bubble, medium bubble, and large bubble. It depends from the diameter of the bronchus, but in fact, it's not too important. It's small bubble, medium bubble, or large bubble. How you will to differentiate these bubbles? It's small bubble or medium bubble. Yes, the most important to understand that it's wet. It's wet or dry. The most difference wheezing, dry wheezing and wet wheezing. Yes, and the smaller bubbles depends from the calibrage of the bronchs. Next. Secondary respiratory sounds as crepitus, pleural friction nose, and pleuropericardial nose. So wheezing, dry, wet, crepitus, pleural friction nose, and pleuropericardial nose. I remember. So about mechanism of formation. Formation of wheezing. Wheezing is formed in the trachea, in the lumen of the trachea, in the bronchi, and in the cavities that communicate with the bronchus. About dry wheezing occurs due to an unit in organ of the lumen of the bronchi In case of bronchial obstructive syndrome and infected really spasm of bronchus, including bronchospasm. So, yes, occur due to unidinuorien of the lumen of the bronchi with bronchial obstructive syndrome, including bronchospasm and noradin of the bronchial tree. The former are better had on the phase of expiration and the later mainly on inspiration. Dry wheezing can be heard over the anterior surface of the chest in the basal zones as well as in a limited area which depends on the leading mechanism of their formation. And so about dry wheezing. Yes, the main it's spasm and noradin of the bronchus and increasing in the thicker of the wall of the bronchus. It's the main mechanism of formation of dry wheezing. It can be had, this type of noses can be headed into all surface of the lungs, but more significant is in the basal zones as well as in a limited area. About formation of the wet wheezing, the main condition for formation of wet wheezing is the presence of the liquid secretion of an inflammatory exudate or non-inflammatory transudate nature and blood in the bronchi of various calibers. So the main important point of formation wet wheezing is the presence of fluid. Doesn't matter which type, exudate, transudate, presence of fluid. Wet wheezing are formed when a stream of air, yes, or direct of air pass through a fluid located in the bronchi. Pay attention, presence fluid and air come in and air stream pass through a fluid in the cavity. Look to this picture. Mechanism of formation dry wheezing. Yes, also it's inspiration phase and expiration phase. High of inspiration. Dry wheezing we can detect on the phase of inspiration and expiration also, but look, more red color. Yes, more straight line red color on the phase of expiration. Why? Because we remind with you that spasm, its physiological reaction on the phase of expiration to help the organism want to put out the volume of the air. So level of the bronchospasm more significant and increase in the phase of expiration. That's why dry wheezing more significant in the phase of expiration. But it's not excluded the presence of the dry wheezing in the phase of inspiration. About mechanism formation. Look, first of all spasm, first of all spasm. Second one, increasing in the thicker of the wall of the bronchus due to inflammation, maybe due to not rechangeable, re-exchangeable process due to COPD, yes, and presents a little bit exudates on the bronchus. 3 points. Spasm, thicker of the wall, some fluid, some presence, not fluid, it's not the fluid, it's some mucous substance. So more headed in the phase of expiration, yes, but not excluded on the phase of inspiration, dry wheezing. So continue about mechanism of formation of wet wheezing. So wet wheezing more significant, yes, on the phase of inspiration if it will be present in the cavity. And look to this picture. It's an example, yes. Imagine we discussed with you that the main point information of the wet wheezing is presence of fluid into the cavity. Into the cavity of bronchus, into the cavity of alveolus, into the cavity of abscess, for example. Yes. So, and imagine that this all volume of the air go throughout from this liquid. It's working like air in the cocktail. Yes, try to put an air in the glass of the water or in the glass of the lemonade or such cocktail, protein cocktail. You will find the bubbles. Yes, it's the same mechanism. During inspiration, volume of the air go through this liquid and making bubbles. Clear?
Yes, ma'am.
Yes, ma'am.
Yes, doctor.
Okay, continue. Dry wheezing. Spasm, present some mucous substance, thicker, increasing thicker of the wall. Wet wheezing, the main mechanism, presents fluid inside, yes, inside the cavity, inside the lumen, and more significant in the phase of inspiration, cause air throughout from this volume of the fluid. So continue. Next type of pathological breathing, it's crepitus. Crepitus is a special small crack that occurs when the adhering alveoli stick together under the influence of air entering them during inspiration. The cause of crepitus are inflammatory lung infiltration, atelectasis, and pulmonary edema. Conditions for the occurrence of crepitus are the presence of the fluid filling the alveoli of a large amount of fibrin, which determines its increased density. So, in case of wet wheezing, presence only fluid, but in case of crepitus, presence the fluid which containing a large amount of fibrin, yes, and so increasing the density of this fluid which present inside the cavity. The place of formation of crepitus is alveoli, and by sounding crepitus can be sonorous and quiet, and the soundness of crepitus depends from the density of the lung tissue. With increasing density, the sound of crepitus increases, and in the depth of the seal areas. So the place of formation of crepitus, it's alveoli, and the main point is fluid inside the cavity of alveoli, but with a large amount of the fibrin. Look about mechanism of formation of crepitus. The same, yes, it's our alveoli. Look, it's healthy alveoli. This form and this position of the wall of alveolus before enter coming air enter air coming in the cavity, expanded walls, increasing volume, re-expanded, vesicular breathing. In case of presence, some fluid with fibrin and this very density substance, and this substance look blocking practically all volus alveolus, and like a layer on the internal part of the alveolar wall, yes, like a layer. And when air coming in the cavity, this fibrin stopped the normal movements of the wall of the alveolus. And but firstly stopped, look, but then some expand, not until the normal level, but some expand, and this fibrin give us this sound of crepitus like a crack. So fibrin increase in density of this insiding fluid and give us some crack like a crepitation. So and look to the graphic of where is I lose commentation, but okay. Look to the graphic of the respiratory cycle. More detectable. Yes.
You cannot see the screen.
What is it, ma'am?
You turn off the screen, shared screen.
Oh, no.
Nothing, ma'am.
Yeah, I see. Yes. Thank you. Yes. All is good?
Yes, ma'am.
Yes, continue.
Yes, ma'am.
So look, look to the graphic of the respiratory, more detectable the presence of the crepitus on the high of inspiration. Why? Look to this. Expanded in the critical moment, in the critical volume of the air inside the cavity of alveolus, and give us this crack. So crepitus detectable on the high point of inspiration. So not forget, pay attention that you need to differentiate it wet wheezing from the crepitus. And the difference between crepitus and wet wheezing is had on inspiration and expiration. Yes, like a cocktail. Yes, like a bubbles on the phase of inspiration, more significant than expiration. But crepitus is only at the high point of inspiration. And we discussed it right now why. And the caliber of wet wheezing changes after coughing, and they are different in timbre and localization. But the nature of the crepitus after coughing does not exchange its monotonous features. So in these cases, for differentiated wet wheezing and crepitus, we need to ask a patient to make a coughing movements. And after coughing, we continue our auscultation on the same point of auscultation and considering these 2 dates, before coughing and after coughing. So in case of wet wheezing will be changed after coughing. Crepitus, no, not change after coughing, will be the same sounds in the same point of auscultation. Very important difference between crepitus and wet wheezing. Abstinent wheezing after coughing and presence constantly crepitus before and after coughing. So the pleural friction nose appears during pleural pathology. Condition for the formation and causes of pleural friction nose. Roundness of the pleural sheath due to their inflammatory edema, first condition. Lack of fibrin on their surface, increasing density, yes, such with the crepitus. Cellular infiltration of the pleura and rash of the tuberculosis nodulus, like a cracking tuberculosis nodulus from in between pleural sheaths. Primary and metastatic lesion of the pleural by a tumor, damage to the pleural sheath with uremia and significant for patient with critical level of the urea, and the dryness during dehydration in patient with diagnosis of dehydration. Look, 7 reasons which can develop onto the formation of the pleural friction noses. Following features of the pleural friction nose. It resembles the creak of snow and the crack of snow, the sounds of snow, like a first snow in the winter. Try to remind such a condition. On the morning, you'll go to the university and press to new snow. So it's a creak of snow. It's really the same sounds. And the sounds that occur when fingers or pieces of papers or rubble by the ear. Yeah, maybe a crack of paper, but bad example, it's a crack of snow. Next features, intermittent, is had an inhalation and exhalation and perceived as a sound located close to the surface of the chest. So in the zones close to the surface of the chest. Next features of the pleural friction nose, unstable. In the dynamics of abscissation can vary in intensity and timbre, and simultaneous crepitus or wet wheezing. More often can simulate crepitus or wet wheezing, and in this case we need to differentiate it, crepitus, wet wheezing, and pleural friction nose. And look, not attention to Russian words. Look, the place of formation of the pleural friction nodes, it's between the two pleural sheets, parietal, yes, and visceral sheets, exactly there. After different type of inflammation. In case of dehydration, when no normally elasticity and no normally structure of the sheets. So in case of presence, there's something, yes, it's the main moment of formation, pleural friction nodes, contact parietal sheet and visceral sheet of the pleura. The last moment in auscultation, it's only like a method, it's bronchophony. Practically, it's the similar method with the waist trembling, but using Stethophan endoscope. Bronchophony, conduction whispering speech from the larynx along the air column of the trachea and bronchi through the lower of alveoli on the surface of the chest. So it's conducting, yes, whispering included sound from the larynx to the facies of the lungs, and we will determine it by the Stethophan endoscopes. For this purpose, the patient utters on the whisper words containing loud sounds like 33, 31, 32, 33, or hissing sounds in Russian and chashka chaya, or including letter sh or sound sh. To identify bronchophony, you should listen to the entire surface of the chest and comparing the sounds in symmetrical areas as with auscultation. So you ask a patient to tell 33, like a whispering 33, yes, and continue making auscultation in the similar points of auscultation as usually. And look, it's methodic, yes. Normally points for auscultation from anterior part, yes, from posterior part. About interpretation results of bronchophony. Normally, the spoken word sounds inaudible. It's impossible to differentiate it, which type of sound spoke our patient. But in case where condition arises for a better conduct of oscillation from the larynx, the sounds become more clear in your Stethophan endoscope, and you can hear individually words. You can separately understand the words which speech a patient. In a healthy person, quant sounds or rustling are heard. And in the case of presence of fluid, like a hydrothorax, like an exudative pleurisy between the sheets, or a large amount of the air in case of emphysema and pneumothorax, bronchophony is reduced. It's normally because it's working like additional layer. Yes, the same mechanism. And if you try to understand the mechanism of formation waist trembling and the base of waist trembling, you will understand the mechanism of development bronchophony and interpretation of bronchophony, and also reason of attenuation, pathological attenuation of vesicular breathing. So bronchophony is especially valuable for the early diagnosis of pneumonia. Then dullness is still not very pronounced. Yes, during percussion you can determine exactly dull or ephemeral type of sound above elation. Breathing is uncertain and waist conduction is unhate. With a small amount of focal of compaction, waist trembling may not be enhanced at all, and bronchial breathing may be absent, while bronchophony already undoubtedly reveals a focal of compaction. So in the first moment of pneumonia, in the early stages, more significant such method like a bronchophony, because we cannot find exactly phenomena of dullness, phenomena of formation of bronchial breathing in abnormal areas, because density not critical. So we finished for today. I hope you was interested by this lecture about auscultation.